Thank you to everyone for joining us, and thank you to our expert panel. We're so happy that you make the time to join us today for this exciting event. This is an event being put in celebration of the Black History Month by the African Studies Department at BMT University, and I have the privilege and honor of serving as the chair of the department. So once again, welcome to everyone, and thank you for joining us. So as I mentioned before, this event is in celebration of the Black History Month, and these came out of recognizing that despite the pandemic that is ongoing, there's a lot of effort now focused on the Black community, but more importantly, there's a lot of news about what the Black community is doing about this pandemic in light of the COVID-19 vaccine. So there are questions that must be answered. There are things that must be done. However, we want to focus on the strength within the Black community. So it's really my privilege and excitement to bring this able panel to speak to this issue of COVID-19 vaccine and the power of resilience within the Black community. And so to get us started, because we don't want to take too much time, I would go ahead and introduce our panelists to you all, and then they are going to present. And after everyone has presented is when it will be open up for questions and comments. And so to our participants that are viewing us, please take the time to, write your comments or questions in the chat box. I will try my best to get to that chat box as soon as possible to have the panelists answer your question. So to start us off, we're going to introduce the panelists. I want to start out by first talking about our first panelist, Dr. Vivian Carter. Dr. Vivian is the chair of the Department of Psychology and Sociology and Deputy Director of Community Engagement for the Tuskegee University Health Disparity Institute at Tuskegee University. She's the past president of the National HBCU Research Network for Research and Health Disparities. And Dr. Carter is also the former Assistant Director for Community Outreach with the Tuskegee National Center for Bioethics. Dr. Carter is an experienced social scientist with specialties in organizational development and transformation, medical sociology, race and gender relations. Dr. Carter is an accomplished researcher that specializes in community-based participatory research and serves as a cancer outreach team leader and Tuskegee University primary investigator for the cancer outreach components of the U54 Cancer Research Partnership funded by the National Institute of Health. Dr. Carter has worked internationally with many organizations, including the United Nations Women Coalition, to address sexual assault and gender violence in African college campuses. She also serves on several community boards, including the Alabama HIV Task Force. Dr. Carter is a co-author of 3 community-based cancer research studies that have had dramatic impact on health outcomes for women and men in Alabama. And Dr. Carter, of course, has served as a reviewer for many leading journals in this area. Dr. Carter, it's our pleasure, and on behalf of the African Studies Department, I want to welcome you to this panel and to this webinar. Welcome. The next person I'm going to introduce is, of course, Dr. Isari Ifedi. Dr. Ifedi is an associate professor of education at Antland University. She has authored books and book chapters and articles, and of course has presented nationally and internationally. Her first book, which is African-Born Women, Faculty in the US, Lives in Contradiction, was very interesting read and take on this particular population of academics in the diaspora. Dr. Ifedi was elected as the inaugural chair of Ohio New African Immigrant Commission from 2017 to 2019 by the former governor of Ohio State, Governor John Kashi in 2017. The New African Immigrant Commission was created by the consent of the Ohio governor and legislature to advocate for Africans in Ohio. So Dr. Fedi also chairs the subcommittee on African immigrants, City of Columbus and Franklin County, for the 2020 US Census Complete Count Committee, which of course co-chaired by the mayor Andrew Ginter, and the former County Commissioner, Kevin Boyce. So Dr. Fedi's research examined the intersections of race and identity for immigrant students and teachers who work with ELS students. So Dr. Fedi, thank you and welcome on our panel. And of course, our third panelist is Dr. Sharon Morrison. She's a professor in the Department of Public Health Education at the University of North Carolina, Greensboro. And she's a research fellow with the Center for the New North Carolinas at UNCG. She's a community-based engaged scholar whose teaching, interdisciplinary research, and service are focused on global and transnational health issues, including the social integration, cultural adaptation, and health and empowerment of racially and ethnically diverse immigrants and refugees. Her most recent project includes a focus on local immigrants and refugee community mobilization and responses to COVID-19 and other emergent challenges. Professor Morrison is a member of the National COVID-19 Prevention Network, African American/Black Expert Panel, organized by the National Institute of Allergy and Infectious Diseases at NIH. She's the recipient of the 2017 UNC Board of Governors Teaching Excellence Award, the 2019 Community Impact and Outcomes Award from the International Association for Research on Service Learning and Community Engagement, and the 2021 Thomas Undergraduate Research Mentor Award for tenured faculty at UNCG. Dr. Morrison, welcome to the team. Thank you so much for giving us your time. And finally, last but not the least, definitely, we have Dr. Kim Garland. Dr. Garland is an associate professor of history at Purdue University and the founder and director of COVID Black, an organization that works at the intersection of health data, information, the humanities, race, technology, and social justice. So Dr. Garland, welcome also to the panel. So once again, thank you so much for giving us your time. As I discussed, you all have about 15 minutes to present. And so we're going to start off with Dr. Vivian Carter for her to give a presentation. And I'm going to turn it over to you, Dr. Carter, now, so you can present and talk to us about this issue.
Okay, thank you. Let me pull up my slide here so I can make sure that everyone can see. Okay, let me put that in. Okay. Well, first of all, Dr. Okur, I want to thank you for allowing me to be a part of this wonderful panel. As stated earlier in the introduction, I am here on the campus of Tuskegee University. And yes, I'm going to talk about the elephant in the middle of the room. Whenever anybody hears Tuskegee, the first thing, especially when it talks about healthcare, the first thing that comes to mind is the United States. Understand me. The United States Public Health Service study of untreated syphilis in the Negro male. That is the title that it is filed up under in terms of the research. People always like to say, oh, it's the Tuskegee. It's not the Tuskegee experiment. The Tuskegee experiment is the airmen. Airmen get very angry when they hear people say that. And we're very emphatic about this. It is the United States Public Health Service study of untreated syphilis in the Negro male. The conductors of the study were the United States Public Health Service. It was conducted in Macon County. Now I'm going to give you a little bit of history before I go into what's actually happening in the communities. But I want you to have a little bit of history about Tuskegee itself and its resiliency, because there's no other place that you can look at that you can find this type from the ground up, a dedication to resiliency. The first beginnings of this, I want to, in terms of healthcare, from the very beginning, I will be honest with you, from the very beginning of Tuskegee's existence, because really when Booker T. Washington got here, there was no land, there was just a chicken shack. But he knew what could be possible. And what they did was to pull together money to buy the land. That was done by his then the co-principal, looking at her benefactors, and that was none other than Olivia Davidson. Olivia Davidson got the first $500 that put this university on the map. But Booker T. Washington was always concerned about health, and Hallie Tanner Dillon was the first physician hired at Tuskegee Normal School in 1891. Now, the school opened in 1881, but 1891 is when Hallie Tanner Dillon was hired, not only hired, but he basically ensured that she was tutored to make sure that she could pass the board to be licensed to practice. Now, Hallie Tanner Dillon is the first woman, Black or white, in the state of Alabama to be licensed to practice medicine. That's Tuskegee. That's how committed and concerned Booker T. Washington was about the health of the people. Now, she was treating not only, the faculty on the campus, but she was also she established the Lafayette Infirmary, which later on transitioned into John Andrews Hospital, and she established a nurses training program. Okay, this is all in encompassing with the community. So 1891. Then let's move on. George Washington Carver. Okay, Carver was the head of agriculture, but Carver was much more than that. In 1896, he came to Tuskegee. Carver he saved the South by teaching them how to rotate the crops and by basically industrializing peanut farming. You think he came up with over 300 different combinations for peanuts. He's known for saving the South from the boll weevil. So here we go again, reaching back, Tuskegee coming to the forefront, not only for the community, not only for the Macon County community in which it exists, but the whole state of Alabama, and then for him with dealing with the boll weevil, the whole nation. So that legacy, that resilience, that brilliance that came out of this institution. Now, let's talk about, this is John Andrews Hospital. And again, the clinical society emerged out of John Andrews Hospital. The clinical society, it was at the time, the #1 group for Black physicians. This is where they came to exchange practices and procedures. Now, what is interesting about the clinical society is that they were performing and demonstrating procedures, and they would invite other ethnic groups. They would invite white physicians to come. But what was happening was the white physicians would take and exploit whatever they were doing and say that they discovered it, when these Black physicians had been doing it for years, doing these procedures. This is all recorded in the archives. We have a listing of all of the conferences, all of the society meetings. There's documentation of this. So, this is, again, a very crucial group. You're bringing together all of these Black physicians from across the nation. Charles Drew, when he was killed in the car accident, he was on his way to Tuskegee for a clinical society meeting. And that was orchestrated by Dr. John A. Kinney. Now, each year, the hospital held free medical clinics, and they gave free medical care to the residents of Macon County. Again, people don't understand that. They keep thinking that somehow when the public health service came, they just fell out of the air. They didn't. They came because they knew that this was a qualified healthcare facility that was right here, that was basically geared toward treating Black people, because Black people couldn't be treated, that the white physicians couldn't even touch them. So now you have a facility staffed with qualified Black physicians who were willing and able to treat people not only from the community. You see, they came from Georgia, they came from Louisiana, they came from Mississippi, they came from Florida. That's the other misconception about those participants. They were all from Alabama. No, they were being treated in Alabama, but they weren't from Alabama. A lot of these bordering states came here. I want to talk also about the Tuskegee Veterans Hospital. The land that Veterans Hospital sits in was donated by Tuskegee. It was there because there was no place for Black veterans, men who had basically given their lives for this country, to have adequate access to adequate health care. It is the first and the only Veterans Hospital that is staffed by African Americans. And this hospital is still standing today. And for the most part, it also launched a huge psychiatric treatment program there, which people are not aware of in terms of dealing with a lot of the issues that military men confront after being in the military and going to war. But again, that's part of the Tuskegee. That's what we do. You rise to the occasion. You know what is needed and you do it. I want to move into this concept, and I wish I could say that I came up with this, but this was something in a COVID and Black group that I'm a part of, that Dr. Montgomery Rice interjected about meeting people where they are. As we deal with this issue of this COVID pandemic that we have, and the fact that it is, affecting African American and African communities, all we can just say Black communities at a disparate rate, the way in which it's running through our communities. You have to look at what can we do? And you're finding out that our community organizations are standing ready to work. I've gone in and I've worked with different churches to make sure that they have adequate information and resources. Churches are purchasing their own resources. And as you know, many churches now are what we call mega churches. So they have outreach components and groups that can administer health. We have parish nurses. Macon County has the largest number of retired nurses in the whole state of Alabama. These women are phenomenal. They teach me every day. And they're not just an Alabama network. This is a national network. These women are up, they're running, they're on the front lines. A lot of times when you see these people at these vaccination and the screening centers, a lot of them are parish nurses that have come out of retirement to do what they know to do, putting their lives, on the line. And then you think about your retail stores, just basically having them have that little table. I don't know if you've gone into your Lowe's or your Home Depots, just having that little table with the mask and the sanitizer, just in case you forgot, that's there. Building codes, those things are crucial. And let's talk about our community organizations. We have the community organizations, the Urban League, the NAACP. Now, come on, we need to talk about the Divine Nine. Those organizations have done a phenomenal, the way they work in terms of the political stream, they're mounting up in the same way to try to address this issue. So we got to tap into that and support that. They're doing the heavy lifting. They're not getting the recognition for it, but they're there and we need to make use of it and recognize it. I want to talk about community testing as well. A lot of people with the testing centers, we open them up, but where we're opening them up is you got to get crucial. Again, going back to that concept, meeting people where they are. Okay, we're in a rural community in Alabama. Okay, so we've got people trained now, navigators trained that can go door to door to help people to screen them, to be screened for COVID. Okay, we're going to be trying to set up community sites for vaccinations so that people don't, a lot of people don't have transportation. Everybody think everybody's got a car. Everybody doesn't have a car. We don't have mass transit in Macon County. So either you have a car or you walk. So you got to find that place where most people can walk to or get to in order to set up your sites. Those are the things that can be done readily, easily, mobilizing. Webinars, just like this one. Now, some popular webinars that have come up, and they're wonderful. And I say, and I understand everybody does not have broadband to where they can access the internet. But for the most part, we have blackdoctors.org, because people are very skeptical about this information. Where is this? Who's delivering this information? Where's it coming from? I don't trust. If it's coming from the government, I don't trust the government. But one lady told me, she said, I don't trust what that Foshi man says, but Dr. Carter, I trust you. I trust Tuskegee University to tell me whether this is correct or not. So you want to get that information out with credible groups. And so then we have blackdoctors.org that this is online. You have the COVID and Black series. It's a whole series where we're addressing it from different ethnic groups. And it's perfect for that group that can access this information. But those networks are up. This is what this is the resilience. This is what we do. Town halls, that's another one. And this particular town hall was sponsored by the Urban League. And again, bringing people together with again, credible groups that they trust to deliver information that is valid. And then the other thing is, you've got to give it to people in layman terms. We cannot sit back and be so scientific about what we're explaining when we're talking to the community. You need to be able to, I tell people, when I'm talking to the community, I'm printing things and speaking at a 5th grade level. And this is very, very basic and very general so that it's understandable. So that we have these town halls where communities can access, and they have access to radio, television, their local city council meetings. We're there to deliver this information so that, and if they have questions, always you want somebody that they can reach out to in their community that they know that they can ask those questions and get answers from. Now, in terms of looking at the scientific component of it, we have got to, there are Black scientists who are involved in the study, in the distribution, but we don't hear about them or we don't see them. So there's been a lot of effort to make sure that minorities are that are on the forefront of this are being featured. We need to have more minority representation in the fields, writing, changing the way in which we engage, because who knows best about how to reach you than you? Who knows your community better than you do? You do. But that's not what you're being taught when you go into what we call the standardized training. So we need to step back and retrain people so that it comes from our perspective. get it into the training manuals, because we're still dealing with what I call delayed discrimination. That delayed, though, those, whether we like it or not, subconsciously, we all have prejudices, and they seep into practice. That's the reason why when you can tell the difference when an African American goes in complaining of pain and when a Caucasian goes in, one gets treated and one does not. One gets pain medication and one does not. Now, I'm not just saying that because off the top of my head, that's documented data that shows this. So we know that this occurs. So we've got, again, but that's part of that subconscious training that makes you make these distinctions between these individuals and make judgments that are unfounded. So we got to retrain. But you can't do that without people who look like us, who are the ones experiencing this, putting that into the training models. But you got to get there. We need to be recruiting and training more minority professional researchers and doctors and getting them into the education process. Tuskegee University, and this is about dealing with philanthropy. I really want to make an appeal to philanthropists to start investing in HBCUs. If you're really serious about doing something, about making a contribution and addressing the disparities, you got to go to the people who can do it. We are the ones who can do it. Let me give you an example. When the state of Alabama ran out of testing materials, the transport material for screening, Tuskegee researchers went into their labs and they made it. They made enough to give to the state of Alabama to make sure that everybody in Alabama could be screened. When other states were screaming and running out of medium, we had more than enough because of Tuskegee. Okay, Thermo Fisher heard about it and said, let's invest in and let's give you. We won't, give you money, but you can have we give you equipment. That's fine. We'll take the equipment because we can do more with that. Okay, and then that's what we did. That's how the diagnostic center came up. And now we're able to start looking at biospecimens, biobanking. We're doing a lot of work, and we're doing some of it through Dr. Clayton Yates, who's a magnificent young man, a young biologist, and just fantastic, who has been working overseas already with what we call the Iron Man project, which is looking at gathering prostate cancer samples from Black men all over the globe, so that we can begin to address and look at this prostate cancer and what we can actually do to treat these men in a more humane way so that they don't die, so that they don't lose their livelihood and their vitality. So, there's some, I just can't, I get so excited about it. And to let you know that investing in HBCUs is going to lead us to to a lot of the innovations. Partnering, I've been a part for 20 years of a cancer research partnership that has done some great work. But it's because not only has the PWI benefited, but the HBCU has as well, and they recognize, oh my God, they know what they're doing. I heard one lady say, well, Dr. Carter, you know what? I'm going to sit back and learn from you because I've been doing this for how many years, and I'm recognizing that maybe I've been doing it wrong. Well, that's because you've been looking on the outside. I'm in the inside. When I look at this group, I'm looking at my mother, my grandmother. It's me. And I can definitely tell you about what I need better than you can tell me. And so this is what we need to be doing. We need to be looking at this from a whole nother lens and begin to understand that if we really are serious about addressing these problems, we need to take a serious look internally at what is already happening and how we can best improve. I thank you.
Thank you so much, Dr. Carter. That gave us a lot to think about, and I really appreciate the work being done. We're going to turn it over now I have some questions that will be at the end of it. We're going to turn it over now to Dr. Ifedi. Dr. Ifedi, you could take it on, please.
Absolutely. Thank you very much. Titi, it's just a pleasure meeting you and being part of this panel. I've already met some of the panelists and I'm just outstanding. Thank you, Dr. Carter. Your passion in this is also just amazing. So I hope I'm being timed, or I'll keep talking to the rest. So what a pleasure to be part of this panel. I come from a non-medical point of view, so to speak. I am not a medical doctor. I am not anything in the medical profession at all. But nonetheless, am I sharing my screen yet? Let's see.
No, not yet. Please go ahead.
Okay. So I'm an educator. Okay, there it is. I'm an educator, and just being part of this panel, I think I'm going to bring in, hopefully, the aspect of just community engagement and involvement. So a little bit of my background. Thank you for the introduction. That was so well done. These are some pictures of some of the things I'm going to be touching on. I hope it's being seen now, my screen. So let me put it on slideshow.
Yeah, slideshow. Yes.
Yeah. Okay.
No, you're not on slideshow yet.
It's not?
No. So go down to the bottom and select slideshow.
Oh, there it is. It should be in a second from the beginning. Yeah.
Yes.
There it is. So I teach at an educational institution, and just in terms of introducing myself, part of my work, my research, and then my teaching, and then obviously my service just ties in all this as far as working with our people, African people. And I love the part that we're looking at this from the perspective that we bring different perspectives to the table. As much as we confront the same issues, the solutions may be different. So here we're talking about COVID, but I'm going to take us back to a little bit of historical memory of where we come from. So back in 2008, my first dissertation, my research on African-born faculty in the US exposed me to the identity question. Honestly, I didn't go into the study with the idea that I'll come out knowing that our identities are fluid, our identities change, they grow. And even if we recognize the differences, for instance, between Blacks who are not a homogeneous group at all, or Blacks in the diaspora, it still means that we give credence to where people come from. Because as we find out, and so with that study, I got into quite a bit of critical race theory, which examines that fundamental aspect of voice, that many times people's stories are being told by other people. Dr. Carter just referred to that. And so it's so important from the CRT, critical race theory, that people are allowed to tell their own stories. Because when I tell my story, I'm telling it from a lived experience. So talking with all these women from my study, there were 9 of them from different parts of Africa, and their experiences in America and back home in different countries, just opened me up to the point that even with the students we work with, and then my work developed more into EL students, it's important to hear their voices, to hear the resilience they come with, to hear about their stories, even if they came through a refugee camp. And so again, working with teachers, teaching teachers, getting their master's degree, this has been a running theme. I mentioned this other study I did, or write-up I did a few years back. In the US, the norm has always been spoken from a certain standpoint, which mostly is white. And so many times people say, why do we have to do this? Why do we have to have a Black History Month? Why do we have to? Because the norm has been white. And so we don't recognize the norm is white because that's norm. That's how things have been done. And so again, experiences of Black faculty, African women, African men is important to be told. So this particular write-up, and it was a collaboration of diasporan women, was an experience I had at my campus on just the double standards we see in the workplace, in where we live, in how we work, and all this will roll into really how everything we experience is important to be told from our viewpoint. So let me kind of move along there. I've talked about community engagement, and I'm talking more or less now about how we involve people in the work we do. As I became the chair of the African Immigrants Commission, which I'll talk about a little bit more, it allowed me to get into talking with community leaders. As part of what community leaders do, their voices are trusted by their own people. So when you look in Ohio, we did the New African Immigrants Commission, actually, we've written 2 reports now, 2018 and 2019, annual reports, and it's on the website. As much as we think of Ohio as a very maybe homogeneous state, the number and the percentage of African immigrants had grown. And so that became a rallying point to even create the commission itself. And the first 2 years as I chaired the commission was just to get in and talk to the community. So we did listening events throughout the state, in Columbus, in Cincinnati, up to Cleveland, the major cities in Ohio, and we got to hear from people. We got to hear from the leaders of the community. And this is so important as it laid the groundwork for what was to come. And I say this because many times there's no structure at all to engage our communities. So we talk about community-based organizations. Many Africans will come in here, and the first thing they want to do is, of course, meet people from their countries and join organizations. And that is important in the work we do, whether in education, in healthcare, and all over. It's important to sort of recognize not just the faith-based, but also these community-based organizations, because they become integral. So these were some of the meetings we did as we got into the work of the census. The census, for instance, was a difficult task at first. People were scared about the citizenship question. People were saying, I'm not going to do it. I don't want to be counted. The government, there's so much mistrust of the government anyway. So how did we do it in Ohio was to talk to the leaders. We engaged them again in meetings, in trainings, to say, this is really what the census is all about. And yes, you do want to be counted. And I can't show all the things, but we did fairs. We went into their communities, spoke to them, did trainings. And these are some of the pictures from that. Hule there is a community leader from Mauritania. She was just instrumental in the work we did with the census. And as I say this, when COVID hit, we were in the middle of the census, trying to do the count, trying to educate, and then everything stopped. It's important for these indigenous and just engaged communities to be nimble, to be responsive. It was amazing. With the census, we recognized the fact that, yes, there were a lot of literature being sent out to people, but we recognized that many of the people needed audio-visual materials. They needed materials in their languages. At this point, everything was being sent out in English. And then some things were translated to Somalian languages, but it still wasn't enough. So the switch from the census to COVID was so almost seamless. We kept the same groups together. Now we said, we're going to have to produce materials for COVID in all these languages, Arabic, French, you name it. And the teams came together to work together to do this. And so again, the work of the commission, the work of the census committees came together. We didn't make any distinctions between those things. And we began to help with the testing. We began to help. So you can see one of the drive-up testings we organized, and that work just flowed in, and people trusted to go ahead and do the testing. They trusted to go ahead and do all the other things they needed to do, social distancing, audio, visual, just materials produced in their own languages. Many of the CBOs also got engaged. So Kenyans, there was the KESA organization, Somalians, Nigerians in diaspora, faith-based African Christian Fellowship, all these groups have been integral in the work we've been doing so far, talking to their own people, producing materials for their own people, and therefore making it legitimate. Not only do we go back to the government, we have weekly meetings up till now with community health-based organizations, with the city, with the state, but we're working together to make sure the right story gets told, the myths are dismissed, dispelled, and accurate information is given to our people. And last but not the least, I want to show this because I think also, as we just said, it's important for people to trust who's doing the work, who's produced the work. Dr. Obwagu was the Yale researcher that was involved in the Pfizer work, in the Pfizer testing. We took that out, we spread the word. He also came on Zoom. We had so many Zoom meetings where we told people, look, he's African, he helped develop this vaccine. And so even getting his own shot, it's important for people to see and relate to these same pictures. So all over on Facebook and social media, we shared information like this. All the doctors and family members, that's my sister, she's a cardiologist, and when she got her, she shared it. She shared it across platforms just to give that validity and confidence to our people. So I want to say this, and I know my time may be coming up very soon. When we share information on COVID and now the vaccination, honestly, as far as I know, people in Ohio who have, because Ohio, we're doing the staggered rollout of the vaccination, I don't know anybody who hasn't had it that's been qualified. The problem has been the problem of access, having enough quantity, but people have the confidence because we laid that groundwork, we laid the foundation for it to take place. And so again, in the church, we talk about it. When it gets to your turn, you're going to get it. And so far, people are being so much more trusting of the process because of all these other things that have happened prior to getting to this stage. So we cannot overemphasize the importance of trusted voices, trusted community-based organizations that get involved, the process of collaboration. So it's not just that they see the government, quote unquote, but they see the government with their own people working to make things available. And so it's going to be, and if we have time, I know questions will come later. We can talk about Africa and what's happening there as well, right? It's important that all those things also, there's a networking happening between us and people in Africa. So I'll stop for now so other people can talk and then we'll get to the questions. Thank you very much, Dr.
Thank you so much, Dr. Fedi. Very exciting. I'm very, this is really exciting for me because I have a lot of notes and I like the overlap in some of the things we're saying. So now we're going to have Dr. Morrison present. I'm going to turn it over to you, Professor Morrison. Please go ahead.
Okay, can everyone hear me okay? Wonderful. Once again, thank you for having me here. And I want to talk a little bit about the local experience here. I'm in Greensboro, North Carolina, and sort of pitch this as looking again at the contributions of Black immigrants to our communities and what is at stake for them during this COVID pandemic. And so I wanted to put this up front. Black immigrant domestic workers are at the epicenter of three converging storms: the pandemic, the resulting economic depression, and of course, last but by no means least, structural racism. And so I wanted to launch into our discussion here in terms of Black immigrants and in particular COVID-19 vaccines, and think about how can we harness the power of resilience at our local level, given that we have a heterogeneous Black immigrant community right here in North Carolina, as well as in Greensboro.
You're muted, Dr. Morrison. Sorry.
Black immigrants, I really like this because they're at the helm of the healthcare and other essential industries. So the contributions have been many. When we look at the data, when we look at Black immigrants, we see that 9.4% of health aides are Black immigrants. A proportion more than 7 times the Black immigrant share of the total population. So they are actively engaged in the top 10 states. The Black immigrant share of healthcare workers is above the general population share. And these are some interesting, what I think, just points to think about contributions.
You're muted.
In the wake of COVID. Black immigrants, we saw a major issue arise when we had COVID lockdowns, because Black immigrants are a big part of our US food supply chain. If you think about it, we've got 2.3% of all food production workers are Black immigrants. That's a large enough number. And the largest number of Black immigrant workers in the US supply chain work in the food service sector. So when we had lockdowns in our restaurants, as well as in our state production plants, such as chicken plants, etc., we knew right off the bat that families were going to suffer because we had pulled these individuals out of gainful employment. Black immigrants are part of the educational services. Imagine K through 12 education, a big sector, and even the childcare services, a big sector. Black immigrants contribute to these sectors. And so all this is said to say that when you look at the contribution of this demographic, it is a wonder that the contributions in terms of what they get back, there's a disparity. And so we, in thinking about our own COVID outreach and the ongoing COVID vaccine uptake, we're continuing to see some of these disparities. At the same time, we are working together, and as my colleagues have already talked about, partnerships, bringing together strengths, the strength of collaboration and partnerships to really address the needs of Black immigrants. So in North Carolina, 8% of the state's population would be foreign-born or considered immigrant. And immigrants are an integral part of the communities here. Contrary to popular belief, the majority of folks here are interested in a path to citizenship. So more than 1/3 of all immigrants in North Carolina are naturalized US citizens. And the majority of the immigrants, 72%, actually speak English. They speak it well or very well. And so this is a state with an immigrant pool. It's a state also with a large number of HBCUs. And these have been an integral part, again, of civil rights here, making strides for education, health, and other areas for people of color, for Black people, for African Americans, and other folks of color. And so there's this immigrant pull. The weather is good, so we've got a lot of folks coming down from secondary migration from colder states. And we also have a vibrant agricultural industry. So there's a lot of pull in this region. The other thing in this region is this whole idea of refugee resettlement. We are a refugee resettlement site. And North Carolina has successfully been one of these sites with a number of refugee resettlement agencies with a history since the 1980s, early 1980s, of bringing folks here and helping them integrate into society. More recent arrivals have come from many of the conflicts, ongoing historical conflicts in regions of the world. And when we look at our immigrant population, we have substantive populations from Southeast Asia, but more recently, large percentage coming in from the Democratic Republic of Congo. And so my work has taken me into working with, over the years here, a number of Black immigrants from across continental Africa and the Caribbean, and more recently a focus on the Congolese refugee population that have been in our community. Now, I want to emphasize for us here in our cities, and I'm in Greensboro, North Carolina. So Charlotte, our big hub, is our big hub for refugees, and then followed by Raleigh, the capital. But Greensboro, right smack in the center of the state, is also well noted for this refugee resettlement process. And what do refugees contribute? When we look, local spending, unique skills. Many have multiple languages. In fact, we have over 90 languages in our school system. We've got community leadership. We have an international advisory committee now for our city, headed up by a former refugee from the Sudan. We have innovation, small business. Many are entrepreneurs, cultural diversity. We've been able to host for the past several years, of course, COVID now shutting it down, but national festival, music arts festival in which many feature their cultural arts. And then state and local taxes is contributing. These are consumers. And there are tons of other assets. Important to note is in our communities, as you can see, there is a lot of collaboration, both with the resettlement organizations, higher educations, education business leaders, as well as the communities themselves that have organized and formed hubs to be able to claim what they need when they need it. And this constitutes a certain level of resiliency, because when you look, many of these individuals have survived war and political conflicts. They've undergone dislocation from where they know their lands and their families and extended families. Many have had to live in refugee camps in other areas. They cannot be repatriated to where they came from, and then undergo an arduous resettlement process, which many people don't know. It takes several years. And so with our past laws shutting down the refugee or limiting the refugee program, these past few years, we've seen families who were set to unite still remain fractured. And finally, the tremendous amount of resiliency as you have had to integrate into multiple new systems, both you and your families. And so for the work that I'm doing and for what we've been looking at when it comes to COVID, it is the resiliency of being able to withstand, overcome, and move forward from some of these arduous types of life events, adverse life events. We've been working in those contexts to be able to address the COVID pandemic, as well as be able to now move to the next level where we are, vaccine uptake. There is no secret as to the kinds of challenges immigrants face and how they are exacerbated during this COVID pandemic. There are many. There's the medical side. There's this higher COVID morbidity, mortality that we see among immigrants. Black immigrants are no less at risk. In fact, they are continue to be an underserved community. when we had to move, for those of you who are educators, to the virtual scenario, many of these households suffered because of the digital divide. And finally, many of these households, not only did they lose jobs, but they lost the stability of their household, the security, the food security, the health security. So these are some of the challenging issues that we've had to deal with. Nonetheless, we've been able to mobilize and move forward, getting PPE out to families, food and other household supplies, working with a group of talented individuals. And now here we are, and I want to focus in, given time, I thought I'd focus in on this whole idea of the vaccines, because that's where we are, and we are continuing to see the disparities play out with the vaccines. The vaccine hesitancy is alive and well in our Black immigrant community. And this is for many reasons. And so I've titled this Paradoxical. Immunizations are not new to many of our Black immigrants. Many are from the Caribbean. Many are from various areas in continental Africa and from Central America. But our Black immigrants are not immunizations are not new. However, given the time we're living in, given the socioeconomic impact of COVID on their lives, given the kinds of mixed messaging that has been happening, and then given the arduous task of trying to engage community in initiatives while they are already experiencing trauma from this, it has been quite a challenge. And this is where our frontline and essential workers have been really, really, really critical. And so I represent here in this talk 3 frontline workers, Lauren, Natasha, and Kelsey. Lauren and Natasha are both refugees. And both of them, one's from Burundi, both of them, they're from Central Africa, both of them working along with Kelsey, who has been training up others, and she is from the North Carolina, training up others to try to address this and work with and for communities. So one of the things I did in preparation for this is to really just have what we call a heart-to-heart Zoom call. And I said to them, here's what I'm about to do. What are your thoughts on this? What would you like me to share about this idea of working with, particularly our newcomers? And some of the common themes that came up, which makes sense when you think of the messaging all through COVID, and here we are, is that many of the Black immigrants they work with have a very wait and see approach to this vaccine uptake. And this wait and see approach has, it's there for many reasons. Fear of dying or being disabled. We have yet to give concrete messaging about what are the outcomes. Folks need to see the outcomes, and we're so new in this process, it's hard to tell. Misinformation from social media. So many conversations about what folks are saying back home. And as you can well imagine, on WhatsApp, Snapchat, Facebook, much of the data going out, many of it is distorted, not because folks don't have a sense, but they have a sense. They've been hearing such mixed messages. And so they are comparing what they're hearing here to what's ongoing back home. And that's one piece of the resiliency part, the push to stay connected even when you're miles away. The prior poor experiences within the US healthcare encounters, our frontline folks have told us that the encounters, so one issue is access, but then the other issue is once you get into the system, language and culture may form a barrier for you to get the care that you need. In fact, as was previously said, treatment may not be forthcoming, or the options presented to you to handle a particular chronic illness may not be the same offered to your white counterparts. And so these communities continue to suffer some of this medical racism. Then lack of information again. If you go to the hospital, you will come back positive for it. Again, our messaging is stay home. If you're ill, don't come for testing. So this messaging, folks have lost individuals who went in to be cared for and never came back out. They went in coughing with flu-like symptoms and never came back. There is also this distrust of US health and political officials. If you think about it, in the last few years, we've had this public charge policy, which means your path to citizenship may be disrupted even if you did everything right. And so many have lost jobs, and needing to rely on governmental resources to get by is a reality. And then the anti-immigrant sentiments, the xenophobia, these policies and the xenophobia has made it very difficult. As Natasha explained to me, those who were here, particularly the Congolese who've been here 4 or 5 years, are a lot more settled and were more prepared to handle the COVID pandemic than the new arrivals who came within the months of the shutdown, who then could not have FaceTime, who then could not connect with the communities that were mobilizing because of social distancing requirements. And then critical piece, and this is a piece I'm working with my students, my student researchers, is to tailor the vaccine information. First of all, accurate and tailored, language specific, culture specific, using words, language, discussion, thoughts coming from the communities to be able to reach and get the message out. So I want to just sort of fold in and then wrap up. I work with a wonderful group of women, Congolese women, the Umoja group. It's a unity group. This started back in 2014 and has been featured, and it started as women wanted to come together. We're in this country. We need to survive. We need to take care of our children. Many of us are single mothers because we've lost the fathers during the conflict. Therefore, we want to survive. And so we started meeting. It started one Saturday a month, sometimes 2 Saturdays. We got together, we ate, we had baby showers, we had celebrations. We figured out how to support during times of illness and death. And so this became a safe harbor, and this safe harbor has now been a venue through which some of the COVID stigma, as well as the vaccine hesitancy, is being addressed. So here we are, a group of us, Natasha, who I call a community model, a leader, Clementine, myself, and the former director of the Center for New North Carolinians. This is us in a partnership meeting beginning to address mental health issues, stressors, child rearing challenges, and how do these women retool to get gainful employment in places other than a chicken plant? And so this is a time of empowerment and leadership. And so leadership rose up during the COVID pandemic. And so I talk about the power of an ambassador. Natasha Nikoke is a Burundi refugee herself, but an advocate, working as a program coordinator, but also just working as a person, a refugee person, a Black immigrant herself. One of the things she's been doing is modeling, making sure the information gets out and modeling herself. And so she was one of the frontline workers to step up and take the vaccine. So she's got her first dose, and now she's waiting on to get her second dose. But she's leading by example, and she's not necessarily shooing away these comments or these concerns, but she's folding them in a discussion to say, this is one of a series of things. You all were immunized as you came here. And so, yes, I understand your paradox, and I understand your wait and see approach. Much of the success is building on the success of the Center for New North Carolinians, a unit of UNC Greensboro. This unit has a center that does outreach. It's one of the only centers on campus that is not research only, but it has an extensive portion of outreach. And they've been building on successes. So they have community centers set up in apartment complexes or housing neighborhoods where refugees have been settled, and they've been using the strategies to promote vaccine uptake in households where you have eligible members. Right now, we're still looking at elderly, but also folks who are frontline workers. And so they're using the flu vaccine strategy to address this. So building on that strength, building on the strength of people who speak multiple languages and understand the cultural nuances and the concerns of these communities. So here we are in the midst of it, plugging along. But as I have seen, coming out of this, we've seen women who normally wouldn't come forward now stepping up to take leadership and explore and examine ways they can then be part of the vaccine uptake to keep their community safe. Thank you.
Thank you so much, Dr. Morrison. Really, really appreciate it. Thank you. So we're going to have, yes, you're still sharing. Thank you. Thank you once again. Exciting presentation to see the work being done in those communities in North Carolina. So definitely last but not the least, we're going to turn it over now to Dr. Kim Garland. And Dr. Garland, please take it off.
Okay, thank you, Dr. Cora and Binghamton Africana Studies Department for hosting this event today. And I couldn't think of a better person to go after than Dr. Morrison. I mean, just for all the panelists, but Dr. Morrison, I think, I'll say this, I will be emailing you after this presentation. So expect an email from me, and you will see in a few seconds why I'm saying this, because what you've beautifully outlined is something that I'm calling, rather than vaccine hesitancy, I want to say vaccine strategic thinking that's coming out of the Black community. And you beautifully outlined it, as well as the other panelists. So I'm going to share my screen. And if I could just hear from someone to make sure that you can see it, I would appreciate it.
Sure. Yes, we can see it.
Okay. So the title of my talk today is, let me just minimize this for a second. The title of my talk today is vaccine strategic thinking in the Black community. So the first thing I want to do is just play a really quick video that gives an overview of COVID Black. COVID Black came out of the pandemic, obviously. It transcends the pandemic in terms of what we are trying to do around Black health data and connecting Black communities to data. So this is just a minute and a half. And again, I just hope you can hear it. So.
We are COVID Black. We are data storytellers, modern day griots, who work at the intersection of health data, information, technology, race, and social justice. We are on a mission to redefine statistics and reinvent the future of Black health by marrying ancestry with data analytics and technology for action and accountability. For us, data is much more than mere ones and zeros. It represents life and holds the key to addressing racial health disparities that impact Black communities. As a Black woman-led and owned data organization, we help healthcare systems, academic institutions, and communities of color solve problems about racism and health through data storytelling and innovative learning solutions. We do this by compiling, analyzing, and visualizing Black health data and information to transform qualitative and quantitative data sets into mixed media stories about people's lives. At the center of our work are 5 key areas: Black health information, healthcare systems, Black lived experiences, Black socio-political communities, and community-focused research. These 5 areas emphasize living data and Black digital ethics, standards that are dedicated to fostering accountability and ensuring that Black people's humanity is recognized online and offline. Join COVID Black in the fight for health equity. Together, we can harness the power of data to end health disparities that harm Black communities.
So that's who COVID Black is, and I hope everyone can see my screen again. We were organized and developed out of a call for more data on the ways that the COVID pandemic was impacting Black communities. As you might remember, in the early days, the data was very disparate and sparse. And so COVID Black came out of this collective effort of myself and some other scholars to develop an organization that was specifically focused on data and Black communities. One of our biggest projects is homegoing. And I couldn't start this project off without talking about the Black communities that have been significantly impacted in terms of the data that has come out on the disproportionate impact of Black Americans. So one of the data stories that we have decided to tell is the lost lives of Black communities. And what you're seeing is a site that memorializes 500 Black Americans. We have more data to add in, more Black lives lost to add in. I'll quickly say that when you click on one of the data symbols, the person's face lights up to the left. The length of the symbol represents the longevity of one's life. The shorter symbols, unfortunately, represent shorter lives. And we've tried to incorporate our West African ancestry of many Black Americans, not all, but many Black Americans, West African ancestry, by pulling in red as a color that is worn at funerals in Ghana, and then using the Adinkra symbol, which I'll talk a little bit about as a representation of the resiliency that Black Americans have. And so this site in many ways is a hallmark of resiliency, because these Black Americans and Black communities signify the resilience of having to lose a lost one. And many who would be here, in my estimation, and I think the data indicates this, if there weren't these disparities that come out of structural racism that make Black Americans vulnerable to COVID-19. But I want to talk about the data around vaccine hesitancy. So there's been a lot of discussion about vaccine hesitancy and race, right? But when you look at who's really hesitant, right? And we can talk about whether we want to even use this word hesitant, it really isn't just Black Americans. In fact, Republicans, which are disproportionately white, are much more hesitant to get the vaccine than even Black Americans. But on the nightly news, in the media, in the sort of public discourse around the vaccine, you hear much more conversation about Black and brown communities as opposed to white communities, right? We heard the same thing when we heard this notion of anti-maskers. It wasn't that these anti-maskers were predominantly white, which they were just anti-maskers and they wanted their independence, or they didn't want to feel as though they were being limited by this government regulation. The anti-mask movement was a racialized movement. And it was largely disproportionately white Americans. So one of the first things that we might consider is changing how we talk about vaccine hesitancy and including particular communities that aren't part of the sort of dominant conversation. I would suggest, though, that we talk about vaccine hesitancy and race in the ways that Black people have long been discussed as a problem to be solved, a problem that is put on the burdens of the federal government, a problem that is representative of just, again, Blackness as being a problem in the United States. So one thing we might want to do is deconstruct this notion of vaccine hesitancy. But to be sure, there are Black Americans that have reservations about taking the COVID-19 vaccine. And Dr. Morrison and the other panelists have talked really eloquently about why this is the case. So I don't want to spend a lot of time on this because I know we want to get to the Q&A section. But this is data from the Kaiser Family Foundation, who has a vaccine monitor, and they're working with Morehouse School of Medicine, as well as the publication, The Undefeated, which is produced by ESPN, but is a Black publication. And what we see is that between September and December, they've been collecting data during this period. We see Black Americans who are not confident about the vaccine development process. And I wanted to say, as a Black person and as someone who's lived through the 4 years of the Trump administration, I'm not sure why many people would be confident about the vaccine development process. So I want to start there, that there are very good reasons to doubt the efficacy of the process because of the administration, the former administration under which the vaccine was developed. But this is some data that you can see here. And that there are still significant numbers of Black Americans that express, and even more so, some faith or belief that the vaccine is safe. And so you'll see with this data that the vaccine, the confidence in COVID-19 vaccine testing did increase from September, right, which is the lighter blue, to December. So you definitely see, with time and more information and more education and conversations, Black Americans as well as Hispanic Americans, their confidence in the testing and the process of the vaccine grows. So again, when we talk about vaccine hesitancy, and I failed to mention that I have a question mark here because I'm not so sure that I buy this vaccine hesitancy sort of discourse. But we do see that vaccine hesitancy is not a stable sort of thing. It changes, and it changes depending on context and information. And as this data suggests, with more information, you will see Black Americans becoming more confident, more Hispanic Americans, and just an overall increase of the efficacy for other communities as well. Same thing, that's a duplication. So I'll just go past that. But what we are seeing is, now that the vaccine is here, that states that are reporting data, and I want to be very clear that right now, about 55% of the states only 55% of the states are actually even reporting data on race and vaccine. And there's a couple of reasons for that. Well, first of all, we're seeing some of a parallel of what we saw in the early days of the pandemic, with not all states collecting or reporting this data. So we need a consistent and a standardized data reporting system. Some public health departments make the data optional. I know for myself, there have been times that I've opted out of putting down my race for a variety of reasons. Because of my history as a Black American, I continue to have strong distrust of institutions, and I don't always check off what my race is. And so there are reasons why the data is sparse, because sometimes people are not checking off this information. And then thirdly, some states are just not collecting it. They don't see it as important, and they're just not collecting the data. So some of the things that we have to realize is that when we look at this data on vaccine hesitancy, it's not always, it's limited, it's sparse, and we still don't know really what the uptake has really been across the entire United States. What you see here, though, is, and I'll just click here into the site, the latest data on COVID-19 vaccinations by state. And what you're going to see, Black is checked off here. In general, in just about every state, African Americans and Black people are underrepresented in proportion to their population in the state, right? So I won't go through this each state, but in general, Black Americans tend to be underrepresented in terms of who is getting vaccinated. So for example, in Mississippi, they're 38% of the population, but they're only 22% of the vaccinations to date. So there's a problem, right? But what is the problem? Is the problem really vaccine hesitancy, or are there other things? Well, I would argue that there are other things in addition to, again, reservations that come out of medical mistrust and a history of scientific racism. I think some of the biggest battles are structural racism, transportation to vaccine sites, and some of this has been already mentioned by my co-panelists. Lack of insurance, or being undocumented, or thinking that you need insurance to get the vaccine, misinformation, disinformation, religious beliefs, lack of faith in Western medicine. And if you had been looking at the news, and I can attest to this from my mom, who lives in North Carolina, who was highly upset when her white neighbor communicated to her that she knew where she could get the vaccine very relatively quickly. And then she gave her the zip code of a predominantly Black neighborhood. There are white Americans going into Black communities and signing up for the vaccine and taking away slots from Black Americans. So that's also a part of the issue that we have to acknowledge. What COVID Black has been trying to do, and this is definitely in the line of what Dr. Morrison is doing, that's why I'm so excited about the work. We've been trying to collect oral histories of what Black people are really thinking and how they are responding to COVID-19 vaccine. We want to get past some of the quantitative data and actually hear the voices. So I have a quick couple clips from a 31-year-old African-American woman. She's a college graduate, went to a HBCU, lives in the South, and she's a parent with a live-in partner. And I just want you to hear what she is thinking about in terms of the COVID-19 vaccine.
As of right now, I would say I wouldn't get it. I mean, I would if, I have enough research, and if I feel like, enough people have gotten it to where it hasn't, have people aren't out here dying off of it. But yeah, I would get it. I don't think I don't know, honestly. Right now, I'm kind of 50-50. Like, I just.
Okay. Make sure. Sorry, I'll go back to that. Let me play the next clip.
As of right now, I would say I wouldn't get it. I mean, I would. I'm not really, I have enough
I'll just
research.
Play this again. Sorry.
If I feel like, enough people have gotten it to where it hasn't, have people aren't out here dying off of it. But yeah, I would get it. I don't think I don't know, honestly. Right now, I'm kind of 50-50. Like, I just.
And let me try to play the next one.
I feel like it's so new, and I'm not the type of person that wants to be the person to test it out first. I just need to see. I need to see a lot more people try it out before I, go and do it. But because right now I haven't been impacted with COVID to where I've been sick or caught it, so I'm just gonna keep doing the same thing I've been doing.
And one more.
To the point, where I'm like, that's my only option, because it's preventable by wearing your mask, washing your hands, and not going, many places. So if I can at least just do what I know I'm supposed to do, then, that gives me some, comfort in knowing that I don't really need the vaccine.
So what you see from her, I'll just say really quickly, and then maybe we can talk about this more in the Q&A, is strategic thinking. She's planning, she's not sure, she wants to wait for research. We tell people all the time, do your research, observe. She wants to do her research. She wants to see what other people are doing. She wants to make sure that it's safe before she takes it. So it's not that she's not going to, and while some people may call that hesitancy, I would say that that's more strategic thinking on her part about when it's safe to get the vaccine, as well, what is the backup plan until she gets the vaccine. And she talks about wearing her mask, washing her hands, and I don't think that's necessarily always represented in data and in surveys when we talk about vaccine hesitancy. So where are we today? Well, the Biden administration's just recently set twin goals of trying to vaccinate people of color and others more vulnerable to COVID-19. Many doctors and Black public health specialists have been asking for the prioritization of Black communities. So they're going to start supplying more vaccine to community health centers where people of color tend to be more likely to be patients, more people, vaccinate more people who might be homeless or poor. And so there is a strategy and an effort to start vaccinating, marginalized communities. But I would say that the vaccine strategies, again, my co-panelists have already said this, so I'll just quickly just sort of, outline these strategies that are already happening on the ground in Black communities all over the United States that really need to be supported, that really need to be emphasized. And this is what we should be talking about in addition to hesitancy or, Black Americans having reservations. Finally, I'll end with the Aya symbol, which is a symbol from a Adinkra symbol from Ghana. And it represents resilience. It's the fern. It represents the ability to endure hardship, but still thrive and survive. And I think it's just the perfect example and symbol of Black communities writ large, Black immigrant communities, African-American communities. I mean, our foundational sort of identity is built on resilience and the capacity to survive against great adversity and odds. So thank you, and I'll stop sharing.
Thank you so very much. This is very exciting. I want to say thank you to our panelists. This is very good. I have some questions. And of course, we're going to open it up now for Q&A. I think I have one of the questions. Somebody had typed in a question here, so that one is directed at Dr. Carter. So I'll ask that question first before I now turn it, I have more questions, and of course I wrote some questions down myself. And this person says they just want to be sure, this is to Dr. Carter, that I want to make sure I did not misunderstood. You said that the Tuskegee Veteran Hospital was the first and only to be staffed by African Americans in general, or only by professionals and African Americans. So the Tuskegee Veterans Hospital. You're muted.
According to record, the Veterans Hospital is the first and only Veterans Hospital to be completely staffed by African-American professionals, nurses, and doctors.
Wonderful. So I have another question. I think this is going to, I think this question is meant for Dr. Garland, but I think any one of you can answer this. So thank you so much for sharing your knowledge. Do you think the racialization of vaccine fear / hesitancy in the media is caused to create a falsified identity or scapegoating on Black individuals and community as a false blame for potential outbreaks or other reasons? So I think this goes to any one of you.
I guess I'll just start really quickly and say that I don't know how intentional scapegoating would be, but what I do know as a historian, there has been a long racialization of disease and infectious disease. We can go back and look at the yellow fever of the late 19th century. We can go back and look at the Spanish flu, of racializing the disease and making Black communities sort of the host of these diseases. So as I think many of us know, we are not that far from this history, and whether unconsciously or intentionally, there has been a long history of the racialization of particular issues in the United States that put the burden and disproportionate responsibility on Black Americans. So I think we need to look at history, let history dictate how we might understand the way the media represents some of the conversations around COVID-19 and the vaccine.
Yeah, go ahead.
Can I jump in there?
Yes.
Thank you. And Dr. Garland, I'm going to your website right after this. I think it's fascinating. And I believe that's also the kind of information we want to get out. Mm-hmm. So it's one thing to own a part of the problem, because there are people who are hesitant, in quote, but don't put us in deficit again. I mean, that's the history of racism. Okay, so when COVID came out too, there was all this talk about Africa will be devastated. It's going to clear up everybody in Africa. And God being God, it did not happen. And I keep saying that we need to tell the story. So while there is hesitance, it's not, we don't own it. We're not that ignorant. And I totally agree with your data that as information has come out, as we've presented faces of people taking it, friends, families, it's changing. People I know are taking it. So don't tell our story. That's part of this. We can tell that story better. So All of us, I'm taking your website and I'm sharing it out as much as I can. Please use it. So thank you.
I wanted to also say, if you think about the rhetoric of the last 4 years, foreigners bringing in diseases and so forth. And so there's this stigma that has been put on people who, what I say, take a wait and see approach, which is what, Dr. Garland, this is what you said. Folks are not, it's not necessarily hesitance, but it's strategic waiting. And so it's a wait and see. And that's across the educational levels. Let me wait and see. And I have had to talk about the vaccine in light of what has happened with a few studies that people are aware of. It wasn't long ago, a few years ago, that women who had breast cancer and survived it were given hormone therapy, hormone replacement therapy. And they were in the midst of this when they stopped the study, because as they started to see, they saw other things occurring. So people are sensible about these kinds of therapies because they know sometimes it's not foolproof. And then when you come from other countries, you have other strategies for dealing with pestilence, is what I call it. And so sometimes that's your first go-to versus Western medicine, or not just Western. People have Western medicine in various areas. So I like the fact people are coming from malaria endemic regions, have to know how to survive that. And therefore, some of those strategies, I think Zika was what we had Zika a few years ago on this side of the hemisphere. And so folks were thinking about their strategies and trying to make decisions and best case scenarios. So I think that, as you say, history will show us, and it's an important piece to consider as we move forward.
Thank you so very much. This is very exciting for me. And like I said, I wrote some questions down. I think it's safe to say that there are common themes even in what you are presented. The idea of meeting people where they are also fits into the idea of using the medium that people are familiar with. So Dr. Carter talked about meeting people where they are. Dr. Ifedi, you talk about using the mediums that are necessary, that people are familiar with, that people are comfortable with. And Dr. Morrison, you talked about the engagement. Who are these people that are becoming the frontline face, as it were? And Dr. Garland, of course, is like, let's just even change it. Let's change the way we're using these words. Don't let us call it exigency. It is strategic thinking, because really that's what it is at the end of the day. And that doesn't have to do with our level of education per se, because even for the educated folk, they are waiting to see how this plays out. And so I really appreciate how all of this kind of feeds into each other. And so one of the questions I think I have for the panel as a whole, that when we talk about meeting people where they are, when we talk about representation matters, when we talk about the words matters, when we talk about communication matters, who is saying what, who can we trust, when we talk about the face of how people are coming together to address this issue and how it impacts Black community. So I'm going to present a scenario, and I want to get your take on how do you think we can help folks on this. We can focus on the strength within the Black community itself versus the deficit model. And so this is it. Here I am as a young person who doesn't know anything yet. I'm a clean slate. I'm a student. I really want to make a difference. I have this energy. I have this push. I just want to leave my mark. How do I take what you've said right now and translate it into action? And I think that's the question I want to present to the community, because a number of the people on this are also students that want to make a difference. So how do we take this and take it into action?
Well, let me start, because in my department, I do have those students and those graduate students with that same fire. And one of the things I ask them is, again, given their focus and their passion, how do you what groups are you a part of? What are you already doing? And then I allow them to network that and infuse that and think about how they can expand that. And really, a lot of my students, that we start with our family. Just with your family. If you feel like, well, I don't feel, like I can go out into the actual community, because sometimes the work that I do is very intimidating for students, because we're all over in the backwoods of Alabama. And we're not only talking to African Americans, we're talking to Hispanics, we're talking, we have a large Caribbean community, as well as a very large African community of from different countries. And so, we bring all of that. We get to, in kind of invade, be the fly on the wall sometimes. And sometimes it's about working with them so that they have the information, and so that we're all comfortable in sharing that. And then they'll go back and they'll say, well, my mother was concerned about this, and I know I'm taking this health disparities course. And so I'm sharing everything we're teaching here, I'm sharing it with my mother. Or else I have students who go to their church groups, they're doing the presentations. So it's about that, kind of like that each one teach one, that little training.
That's beautiful.
I really agree with you, Dr. Carter. One of the strengths of what I do is working with students. I cobble together these teams, and right now I have a student who decided, again, looking, and she's from an indigenous Southeast Asian community, and in her household she's living cross-generational. So grandma and grandpa is over 100 years old, grandma is over 90, and so I've had her doing oral histories with the grandparents and her parents and the aunts, uncles. And then she's brought in another young person. And what it is this is a group where the traditions are dying out, and they're losing elders to chronic illnesses and COVID. And so now they're doing this oral history. And in the midst of COVID, it hit them. They're like, oh, because now something visible is taking their elders out. And so there's a bigger energy to document and get the stories. And they realize that their elders are oral. They're oral, they're not visual, and therefore they couldn't get these stories anywhere else. I also have students who, yes, they wanted to do things. So I suit up with them, and we did PPE supplies out. I got a small grant. I worked with them. They said, well, we want to do, I said, well, let's get an outreach grant. Partnered with an agency, did it. And so food insecurity is a big one. Trying to get food when you're on lockdown. And so food distribution and PPE supplies. And it's amazing. The students light up because they actually feel they're doing something versus reading about something. And so that energy that is there can be channeled, and they learn something, because then when I send them food shopping and they realize, oh, I've got to find and go to the ethnic store, or a store where people like me don't shop and get what there goes the learning that I couldn't have helped them get there without this hands-on. So this is a fantastic opportunity to work with our next generation professionals.
Yeah, I want to disagree with that really quickly, because my first thing, because I'm more closer each day to being an elder than I ever have been. So I like listening to elders, but actually start talking to people in the community. So I don't want to repeat too much what Dr. Morrison said or Dr. Carter said, but really connecting with other people who are doing the work and asking questions and being willing to learn. But I will just add one thing, and this is the thing that I'm really committed to doing, is taking some of the mystique and some of the obscurity out of data, and really having Black people people of color in control of their own data. Too much of the data collection, first of all, is just seen as quantitative data. But then even when we think about the quantitative data, we need to be training more of our young people on how to work with this data and how to use the data for not just raising awareness. I can't tell you how many sort of data reports or dashboards that said that Black people were disproportionately dying. And that's good to raise that awareness. But Dr. Okoro, to your point, we need data for action and accountability. And we need people who can take that data, who are in Black communities, Black and Brown communities, and they can use the data to actually create action and accountability on the ground. Too much of the data collection and visualization is coming from people outside of the community who have good intentions, but data for data awareness, you didn't need data to tell for Black people to know that we were going to be hit hardest. You didn't need the data for that. And I'll just say one thing. Before the mainstream, i.e. white media, started developing data dashboards and task force, guess who had a task force even before the data came out? The Black press. The Black press had the, Black local community newspapers were already on the ground organizing before the data came out because they knew Black lived experience told us all we needed to know about how we needed to prepare. So that's what I would say.
So to jump in there, thank you so much. I tend to really agree with you a lot. To your question, to any student listening to this or anybody who's saying, well, I want to get engaged, okay, don't be dissuaded by so much of what we're talking about. I mean, for us Africans, sometimes in the diaspora, the word volunteerism is a strange word.
Yeah.
Just start small. Connect to a little group, connect to the refugee centers, connect. With students, I actually give assignments and make them go see the other. So if it's African students, go meet white people, just that level of personal, I think, qualitative experience is so important. So start from there, and then the word agency and empowerment come into play. Because you're going to feel empowered once you do that little thing. One of my examples here is a young lady in the community. She's already interested. She came to one of our meetings. She says, Dr. Fedi, I said, you are the perfect person to do this. Let's apply for a grant. I connected her. I don't do grant. Connected her to City. She applied, got the grant, and did a fabulous census, campaign. And so she's still now engaged. She's growing bigger. So each one, teach one, step by step, we can do it. So just encourage people where you are, and young people get involved. At any level, you connect to something bigger that you want to do. So
thank you so much for saying that, because it's one of the things I really want people to take out of this. How can I make a difference? How can I turn this into action of a group? And I love the way you all captured it. Start with your family, for example. Start with your peers. Sometimes you might find your daddy intimidating, and your mama might just be one you don't want to engage with. You can start with your peers, for example, just having that push to say, you know what, let me share what I know. And I also love the point about the issue of data. And I think as a public health person who was trained in quantitative, it's one of the things that is so valued and such that, and I say to my student that quantitative will tell you 60% of the story. Qualitative will tell you 40% of the story, and that 40% of the story is actually what is more important in effecting the change you want than the 60% of the story. And so training students to know that there are values in these ways of knowing outside of the numbers. And I think that's very important. I also think is the point they made about the idea about delayed discrimination, the idea about more representations as a way of addressing this whole issue of delayed discrimination, because it is true, we do have that because of the way people are being trained, that impact how they relate or interact with people that don't look like them. And I think it's safe to say that for all of us on this panel, we kind of experience this one way or the other at some point in time. But the need for data representation is also very essential. Who is telling the story? Who is gathering the story? Who is telling the story? Because you can have folks like me and you in the background gathering the story, but we may not be able to have the platform to tell the story. And yet we know that who is telling the story makes a difference between how people receive the story and how people react to the story. You know, I'll give a case in point. Looking at the big show on Netflix, the Bridgerton story on Netflix, and deconstructing the representation that Chandra put there in talking about this whole war that is open to Black representation in this period piece, and how people are reacting to it. What is funny when I look at what is being said, and I'm looking at this and trying to, you know, nitpick what she did. It's not about the story. Is the who is telling the story, and the way she chose to tell the story made people connect to it, made people see themselves in it. So I think it's essential what you brought out, Dr. Garland, about the need for data gathering, but more importantly, who is gathering the data, who is presenting the data, because all of that is important in the kind of work we do. And I appreciate what is being said about the diversity in the Black community itself, and that is essential to effort to increase vaccine uptake from the point of view that is a wait and see approach. It's not hesitancy, it's strategic thinking about vaccine for Black people and why that is essential for Black people. So because I'm looking at time and I want to make sure we wrap it up on time. So I wanted to find out from any one of you, are there other things you want people to know? I appreciate you sharing your website with us, Dr. Garland. That's very good. I have that copied already, and you did send it to all the participants on this. But I wanted to find out from you, are there other things we should know as we look at the Black community and the COVID-19 vaccine?
So I'd like to ask a question to my co-panelists, particularly Dr. Morrison and Dr. Ifedi. So one of my biggest concerns has been since the beginning of the pandemic is how Black communities from the diaspora, Black communities that are from the continent living here in the United States have largely been left out of the conversations. And as Dr. Morrison pointed out, and Dr. Ifedi pointed out, so many of these communities are on the front line, either as essential workers or in healthcare. And so as an African-American, my question is, how can African Americans bring this conversation about the diversity of Blackness much more to the surface, rather than creating these conversations and these silos that would suggest that the Black community is a monolith, which it's not?
Oh, go. Okay, well, thank you for that question. And I'm going to say, sadly, it's the truth that there's been that divide. The divide hasn't worked well for either of the two groups. And we've worked in research and life and service to bring together. So even when they started New African Immigrants Commission, we had that engagement. We did a community library engagement where everybody came together. And the question, why do you need an African thing now? We're all the same, we're Blacks. And we addressed that, we had an open conversation. Again, sadly, George Floyd brought us all together. Yeah, people came, African born, as I call them, as I call us, came to understand we're all the same. Okay? The police is not going to come out there and say, okay, let me see your passport. No. So some things have happened that now with COVID, we're going to churches that are mixed. We're going to, do Zoom conversations. African Christian Fellowship, for instance, is everybody. We've been doing these Zoom meetings to say we're all in this together. And so the more we can collaborate, the better the outcomes for everybody. So things have happened that have brought us together, and we need to keep working on those relationships we've built. I'm part of other groups that are mostly African American, a family empowerment for parents, and we work together to put people in homes. So same conversation. These things will have to be carried forward as, research we say, where you start, your place of starting is not your place of ending. So there's a starting point, but then your particular becomes universal. So that's what I would say. Again, the research you have there, we've asked the state, for instance, for that breakdown. To your point, and they are not doing it as we want, but I'm going to share your website as well with our state collaborators to say we need this because it's going to help everybody eventually. So just to
Can I just ask real quickly before Dr. Morrison says, is there value in drilling down to get to the specificity of different Black communities? Would that be helpful to collect data on, for example, Nigerian born as opposed to South African born, or just even African born compared to African Americans? I would love to know that type of level of data would be helpful.
Yeah. So I'll give you the example that in the groups that I'm working, I work with Southeast Asians, and there is the model minority myth out there. And so people will see Asians as scientifically gifted and economically stable, et cetera, et cetera. Well, there's a whole diversity in what we call Asian. And what happens is there are these minorities within minorities that are invisible. So I work with an indigenous group called the Montagnards, and North Carolina has the largest group of Montagnards outside of Vietnam, anywhere in the world. And they're localized in this state. And they're not counted. So the community, in partnership with Higher Ed and the youth, launched their own census because they're not counted. And what that means is they can't advocate for resources. So sometimes you have to drill down and make the case to the resource holders that you're not all the same. So in those circumstances, drilling down makes some sense. On the other hand, adversity makes strange bedfellows. So when it comes to the larger advocacy of people of color, we are stronger together than we are apart. But I guess if you've got a family and you've got one child left behind, that's not a strong family. And I think that is the process here. So in order to strengthen, you've got to drill down and find out what are your weakest links. And these invisible groups, their data is subsumed somewhere. And you're trying to explain this data, but how can this be? Because they're the model minority, but you're looking at them homogeneously. And so that's where that merit comes in. And so we work very hard in our community to ironically work together to address. So we have an international advisory committee that looks at, that has everybody on there. So you're getting African American, African, and a range of everybody else that would make up this pot of what I call really a nice palette. And so that is our mayor. This is how she's now operating, because this is the only way to move forward, is to bring these conversations. And what is interesting is the exchange of each other's histories. Education, African Americans educating Africans, Africans educating African Americans. And so now we start to get some traction on how things should move forward. And that's very powerful if you think about forces that easily want to divide. That's a very powerful movement forward.
Thank you so much. We have a quick question from one of the participants, so we can wrap this up. We only have 5 minutes left. This person said, I have a quick question about the clinical society. After the syphilis experiment on Black males, was the clinic discontinued, or did they pick back up afterwards? That's Dr. Carter.
Stan, the clinical society was in place. Okay, the syphilis study. Okay, that is a U.S. Public Health Service study. That is separate.
Okay.
Okay, that is separate from John Andrew. That is separate from Tuskegee and John Andrews Hospital. The syphilis study, it was its own encapsulated event. They knew nothing about it.
Okay.
Okay.
Yes.
It's sometimes I tell people it's like this. It's like when you go to a lab and you get, they draw blood or something and they send it back to your physician.
Yeah.
Okay. If he doesn't tell you what the results were, that lab is not responsible. It's that physician, because he sent that order into you, and for they don't know what they don't know what he's using that for. Mm-hmm. They just told him to draw these tubes of blood and run them through this and send it back.
Yeah.
Okay. So
yeah, thank you so.
All they wanted was that facility. I'm sorry.
Well, thank you so very much. Obviously, we can go on and on about this. Okay, so another student just asked a quick question for Dr. Garland that says, what is the action I'll be taking from the data collected? And I think we kind of address some of this in terms of, ways in which students can start with even what they know. So I think this question is directed at you for the purpose of the data you're collecting right now. What is the action to be taken from that data?
Yeah, great question. I'll just quickly say that the most immediate action is to memorialize Black people and to give them a space. Because so many Black Americans did not have a space to memorialize. We are bringing homegoing into Black communities this spring and summer, where we will project the homegoing memorial on the wall and create community spaces and conversations about Blackness and what it means to grieve through the loss. The other side of that is we're going to be in communities training Black communities, young people, on how to collect and use their own data, how to visualize their data, and just have greater data literacy. So that's the action and accountability piece of it. We want to empower communities to have their own data and then use their data to make decisions about their own lives.
Thank you so very much. We have only a few minutes left. This has been very exciting. Dr. Fedi, you want to say something?
Yes, to Dr. Garland again. Kim, you're so popular here. Well, like I said, I would love to, and I will share this data, but I'm also very cognizant of the power of policy and policymakers. So I'll ask it as a question plus a suggestion. We have a friendlier administration in place, and they've appointed people who are like us, who would listen, who would look at this. Is there any effort on your part to make sure, or kind of to, forward this stuff and make them know that this exists?
Yeah, so we've been building, just really quickly to tell people where the data comes from. We've been scraping obituaries, death announcements, anywhere we can find this data. And to Dr. Morrison's point is, COVID Black may be one of the few places, I think Dr. Morrison's sort of collecting qualitative data, that has collected the data and broken out African Americans from the African diaspora in the continent. So our goal is to show how, and the data reflects that disproportionately people that are coming from the diaspora or the continent are more likely to be healthcare workers and more likely to have died from COVID-19 on the front lines of hospital care. So it's that type of drilling down that we really want to break down sort of this monolith and show how even within Black communities, there are some that may be more vulnerable because of their likelihood to be on the front lines in terms of healthcare, particularly direct care, where you have people who are home health aides, nurses, aides. We haven't even talked about those communities. And those communities, particularly working in nursing homes, tend to be Black immigrants.
Thank you so much. We have a few seconds left. I want to thank all our panelists. We definitely have to have this conversation more. I will reach out to all of you separately after this event, because I think going forward, we want to really do more of things like this. So I want to thank you so much on behalf of African Studies Department, on behalf of BMT University. Thank you so much to each and every one of you for your time, for your expertise, and for joining us on this. We really, really appreciate it. Thank you so very much. I wish you all a wonderful week, and I will be in touch.